Welcome to PAH.TV Clinical Insights. This discussion is about combination therapies in the treatment of PAH and is moderated by Dr. Richard Channick. Our panel discussants are Dr. Richard Krasuski, Dr. Vallerie McLaughlin, Dr. Ioana Preston, and Dr. Sean Studer.
Hello, this is Rich Channick from Mass General Hospital, and I'm delighted to be joined by my expert panel here. Today, we're going to talk about a very important part of what we're evolving to in pulmonary arterial hypertension, the use of combination therapies. We have many approved drugs for this serious condition, and it's only natural that we would be looking at them in combination. And I think there's some recent data that we'll talk about that's come out suggesting a benefit of such an approach. So what I'd like to do, and maybe I'll start with Sean this time, is we have a couple recent trials. One, the Ambition trial, which really attempted to look at one type of combination therapy. Maybe you can put that in a little bit of perspective and tell us very briefly what this Ambition trial was all about.
Sure. So the Ambition trial was a 3-arm trial, and for the first time, I think, really tried to address this question of would a PDE5 alone versus an ERA alone versus both as upfront combination be a better strategy. And the trial shows us that the upfront combination is better than either of the arms separate. It's an important contribution, to be sure. To have this type of data comparing monotherapy versus upfront combination is welcome. I think we're still trying to figure out exactly where to fit it in, because it didn't tell us that putting someone on one agent as monotherapy, monitoring them, and then quickly starting another one, perhaps earlier than we might have years ago, might not have been as efficacious.
So before you go on, when you say it's better, what do you mean by better?
So it reduced the number of failure events. Historically, we looked at 6-minute walk and functional endpoints in the short term. And this trial, Ambition, as well as several others we may get to discuss, really looked at a longer term approach. So what's the chance that if you start this therapy, you're more likely to reach certain goals, like making it to functional class 2. You're more likely to avoid certain other things you don't want to have, like the need for an unexpected additional therapy or the need for a transplant or these type of outcomes. So the upfront combination wasn't just to show that it got you to walk a little bit further over a few months, but really it helped you remain more stable, if you like, or avoid some clinical worsening event over time.
Okay, so then I'll ask Val, you're obviously very familiar with the study. Do you think this is enough to really dictate our treatment, or are there other approaches that we need to consider as well?
Yeah, it's a great question, and as impressive as Ambition was, there are still questions that remain, as Sean points out. So I think that in the more ill patients, for sure, I'm much more aggressive up front. I think, for example, in the functional class 2 patients that Sean was maybe alluding to, monitoring them closely and then adding on therapy if they don't meet certain goals might be a reasonable approach. And a trial to kind of demonstrate that sequential combination therapy approach versus upfront dual therapy approach would be very useful.
And when you say meet certain goals, like what kind of goals would you recommend that we have?
Yeah, I think that we're learning a lot about where we need to get our patients, and the hall walk is important, but it's kind of being demoted in favor of some other more objective data like RV function, like cardiac output on hemodynamics. We look at BNP, functional class. So we need to look at all of those goals in context with the patient, and sometimes we need to adjust our goals for the patient. My 75-year-old 5-foot woman with scleroderma is never going to walk 440 meters, so that's not a reasonable goal for her. But if her RV looks good on echo, I'm pretty happy.
So if 2 drugs are better than 1, or 3 drugs better than 2, and we certainly have the opportunity to use triple combination therapy. Ioana, you probably have some experience of that.
So yes, we are learning from other conditions such as systemic hypertension or even cancer that maybe tackle this deadly disease when it is very severe. With upfront combination of triple therapy should be the way to go. There is some pilot data coming out of Europe that suggests that patients with pulmonary arterial hypertension who present in a very severe stage when treated treated with a prostacyclin therapy, a PDE5 inhibitor, and an ERA at the same time, they tend to improve their hemodynamics better compared with their historic controls that were treated with 1 or 2 therapies. And they seem to stabilize and not need emergent transplantation.
But without a control group, of course.
Without a control group, it's very hard. There has never been head-to-head trials to assess the impact of triple therapy in PAH. Nevertheless, this is a rare disease and a handful of patients who present in very severe stages, so it's very difficult to study in severe patients.
Mm-hmm.
So, Rich, I'm going to play the devil's advocate here, because I think another thing that came out of Ambition was that the risk of side effects goes up as you start combining therapies. I mean, the risk of edema was well over 40% in that particular study. The cost of the medicines is not insignificant when you go and you see whether you can get insurance coverage. And there's actually plenty of data out there in hypertension that actually, combining various agents sometimes actually leads to more non-compliance from the patient. So, I think that while this ambition was obviously very ambitious, I do think that you have to kind of take the good and the bad. And I think if you have somebody that is less symptomatic, I think the idea of starting to combine medications may lead you in a direction you might not want to be in.
But let me be the other devil's advocate, right? And recognize from our databases that the majority of our patients end up on combination therapy, that we do not have one single drug that cures this disease, and then we do need the help to attack more than one pathway that we know is abnormal in these patients.
And I think if you want to sort of look at that, and from your standpoint, you have to say, what could be some of the offsets? If you're going to spend that additional money and have additional side effects, you should have higher expectations for what it's going to deliver. And the hemodynamics in the example of triple combination are impressive, but from an economic standpoint, if you can reduce hospitalizations, keep people employed, do a lot of other things that start to speak to a more economic benefit, something we haven't always looked at in this disease, I think the conversation shifts a little bit, and the cost doesn't become less, but the overall burden of it may be different than just looking at the pure medication.
And I think it becomes a matter of, once you start combining all 3 classes like that, I mean, my guess is you probably get the greatest benefit out of the prostacyclin, and you probably get less from the other agents. But I'm just,
I think
again,
what
if somebody who's that disease, is that sick, obviously.
If I could summarize, is in the absence of direct comparisons between these 2 approaches, we're just, we're speculating with mechanisms, which is very valid. We do it all the time, but we can't really prove that one approach is better than another. But having said that, Val, who, probably has more experience than anybody here in pulmonary arterial hypertension, which is a great compliment, let's walk us through your approach to escalating or combination therapy. Let's say we have a class 3 PAH, sort of typical patient who's moderately symptomatic. What do you do? When do you reassess? When do you add therapy or change therapy? Give us like a quick primer.
Sure. And I'm sure there's patient-specific variables, but just in general, the first thing for a class 3 patient is, for me, is it a class 3 patient with a lot of red flags that I'm worried about. So you can have a class 3 patient who's got a really ugly looking RV and a cardiac index of 2.1, and I'm really worried about that patient, and that patient gets the IV epoprostenol or IV prostacyclin talk from me first. So I think really what you're trying to get at is the class 3 patient who doesn't have those red flags. But a class 3 patient may have some, not as good prognostic indicators, and I think in the current era with the Ambition data, the class 3 patient is probably someone that I might very quickly get on double oral therapy with a PDE5 and an ERA. I think I'm starting to move that direction. I think the Ambition data was strong data. Absent that, I follow those patients really closely. If I only start them on one therapy, my nurses are on the phone with them frequently. I'll see them within a few months, hall walk, echo, what have you, see if we've gotten to goals, and if we haven't, I'll add that second one on very quickly in that sequential route. And
then maybe a third down the road?
Sure. Again, I set the bar pretty high for most patients. Again, there's some variability. The older patients, so the scleroderma patients, again, they may never walk that distance, but I'll still look at their RV. And if they don't get where we want them to get, it's discussing either a prostacyclin, or there's a number of investigational trials going on these days where patients on background therapy can get in. And I always think it's great to add to the knowledge base, to add to the clinical trial data that we have.
Yeah, that's an important point, that most of the newer trials were, in a sense, combination trials, because the majority of patients were already on a single drug and the second drug was added. Practically speaking, Ioana, we come from the same state. Do you ever get coverage issues starting more than one drug at once in terms of payers, or has that been a problem for you?
It's becoming more and more of an issue that, of course, the payers looking at our expensive therapies want hardcore data based on how we practice medicine, right? So yes, and I'm expecting to see more and more. I mean, we have to, wait also for the details of the AMBITION trial to see a responder analysis, subgroup analyses that may help us decide who would be at the most benefit to start combination therapy up front.
Anyone else have those kind of practical issues doing these aggressive approaches?
I think the data is going to help these sort of things, but I would echo what you said. I think for years there was so few patients that a lot of insurers didn't pay close attention necessarily to whether our practice was closely mirroring data or it was largely based on personal judgment. But I think now it's becoming more of an issue in virtually every area outside of PH as well as within. And I think having this data is critical for this, because even though there's some holes and some gaps between what we'd like to see and what we currently have, it's certainly better than not having the combination data, because you can send them something that they can latch on to.
Do you ever stop an agent when you combine these drugs? Do you take away one that, especially when you add on? Is that an approach that has any validity, or do you tend to avoid that?
That's a very good question.
Yeah, I mean, we all have issues taking away therapies in patients with this particular diagnosis. If someone doesn't get better, does that mean that therapy's not doing anything? Does that mean that therapy's halting disease progression, just not getting them as much better as you'd like? They're difficult questions. Often we don't stop unless the patient has had a side effect that's intolerable. And I'm not saying that's right or wrong, that's just what we tend to do.
No,
and I think it's incompletely defined, but there's always the concern too that maybe there'll be some synergy in individual patients. And so if one avenue stabilized, then maybe adding the second will be better than allowing that to change and adding the new one in. So I've been asked that question on a bunch of occasions. Since they are expensive, if you give something and you don't see a patient move towards goals, why don't you withdraw it? And I think it's a general discomfort that we have, but it's hard to put data to this, because there really isn't a
and when your endpoints may be long-term outcome and morbidity, how can you really prove that in an individual patient?
I think the other thing is, I find that when you start tinkering with more than one thing, if you have a problem or if the patient were to worsen, you don't really know what you've done. I mean, I find that if I'm adding a drug, I want to know what that drug does to the patient, not if I take two away and add one, what happens? Is it because I took the drug away that the patient got worse, or is it a problem with the drug? I mean, that's, to me, important to do one thing at a time.
No, absolutely. I guess the last question, and there's not a right answer to this, but this is a difficult question. We have these studies looking at these different combinations. Are they drug-specific or class-specific? It's not an easy question, and I don't expect a definitive answer, but that's a question, because studies are done with specific agents, and can we, for instance, extrapolate to other agents within that class of drugs or not?
Right. I mean, when we teach fellows and teach residents and teach other people that are learning about this, we tell them to try to go based on the evidence-based data. And I think when you have it for certain agents, it's not easy to extrapolate it to classes. I mean, there's a tendency to do that, and if there's a strong reason, if someone was already on a given drug, and I say an ERA, and I wanted to add a PDE5, I might not turn the whole thing around for the withdrawal reasons we just addressed. But that being said, starting up front with certain combinations, I think the ones that were studied and for which we have the best data is the most solid ground that you're on. So it is incompletely answered, but I think going with the data is the best way for them on.
Does anyone feel otherwise?
And I think there's combination data with a lot of different drugs.
Right. No, I think the one thing we have learned is that even though these drugs are in the same class, there are distinct differences in their actions and their side effects, and I tend to agree with that approach as well. Well, I think that's all the time we have. Thank you very much. Another dynamic, interesting discussion. Thank you.